In most instances, there are associated lesions that serve to uncorrect the circulatory patterns. And it is malformations of the tricuspid valve that are the commonest associated lesions. This heart, however, has a much more significant lesion, namely a large ventricular septal defect. And more than half of the patients with congenitally corrected transposition have deficient ventricular septation. We can see here that the aorta is arising anterior and leftward relative to the pulmonary trunk. And that is why oftentimes these hearts are described as showing L transposition. Although, as I will also show you, that is not a defining feature for congenitally corrected transposition. What we see is that the leftward and anterior aorta is arising from the morphologically right ventricle. We know that this is the morphologically right ventricle because of its very coarse apical trabeculations. And what you can see is that the morphologically right ventricle is left-sided. And it is because of this typical left-sided position of the morphologically right ventricle that for many years these hearts were described as having ventricular inversion. I don't particularly like the term ventricular inversion because if I invert this heart, I turn it upside down. And in fact, what we see here is that the morphologically left ventricle is left-sided rather than right-sided, and its feature is that it shows left-hand ventricular topology. What it means is that when I try to place my palmar surface of my hands on this morphologically right ventricle, so that I put my thumb in the inlet valve, my fingers in the outlet valve, it is the palmar surface of my left hand that goes on the septal surface of this morphologically right ventricle. And here you see my thumb is in the inlet valve, my fingers are going up the arterial trunk, the palmar surface of my hand is on the septal surface of this morphologically right ventricle. In the normal heart, it is the right hand that goes on the septal surface. And you know that our hands are mirror images of each other, so the essence of congenitally corrected transposition is that the morphologically right ventricle, in this situation where the patient has usual atrial arrangement, is mirror imaged relative to the anticipated arrangement. We can also see, as we saw in the previous heart, that the morphologically left atrium is where we expect it to be, on the left side of the body, and we can see that it is a morphologically tricuspid valve that is guarding this left atrioventricular junction. So when we turn to the right side of the heart, then as we expect, we find the morphologically right atrium in its usual place. There is usual atrial arrangement, and then this heart shows us very beautifully how it is a morphologically mitral valve that is guarding the right-sided atrioventricular junction, and the morphologically mitral valve is tethered within a right-sided morphologically left ventricle. If I flip back the mitral valve, you can then see the septal surface of this morphologically left ventricle. You see that the septal surface is smooth, and then you see very nicely the fine crisscrossing apical trabeculations that tell us this is a morphologically left ventricle. And now when we look at the outflow tract of this left ventricle, we see that it is the pulmonary trunk that is arising from the left ventricle. We not only have discordant atrioventricular, but we also have discordant ventricular arterial connections, so that the systemic venous return is going to the lungs, but is being pumped by a left rather than a right ventricle. We can see that there is fibrous continuity here between the leaflet of the mitral valve, the leaflets of the pulmonary valve, but then we can also see this extensive and large interventricular communication or ventricular septal defect, which is opening here to the inlet of the morphologically right ventricle. And we can see also that there is fibrous continuity between the leaflets of the pulmonary valve and the tricuspid valve. And if we open the heart now from the left side and we look at the ventricular septal defect through the morphologically right ventricle, we see that its roof is made of fibrous continuity between the leaflet of the tricuspid valve, the leaflet of the pulmonary valve, and it is that feature that tells us that the interventricular communication or ventricular septal defect is perimembranous. There is a membranous septum here, and that is interposing between the morphologically left ventricle and the morphologically left atrium. So here we see one of the lesions that serves to uncorrect the circulatory pattern, a large ventricular septal defect. So of the triad of lesions, you have seen a lesion of the tricuspid valve in the first heart. In this heart you see the second feature, a ventricular septal defect. The third feature is pulmonary stenosis. In fact, we don't have a specimen in our archive to show you pulmonary stenosis, but I will be showing you examples of pulmonary atresia. There is then a fourth complicating feature, and that is problems with the conduction tissue. Now, the problems with the conduction tissue in congenitally corrected transposition reflect the location of the atrioventricular node. The ventricular conduction tissue is carried here astride the crest of the ventricular septum. And because the pulmonary trunk is arising from this morphologically left ventricle, it is deviating the atrial septum away from the ventricular septum. And because of that, the atrioventricular node, the regular atrioventricular node that is situated here at the apex of the triangle of Koch, is unable to contact the ventricular conduction system. As you see, that atrioventricular node is lying above the area of mitral to pulmonary fibrous continuity. So the essence of congenitally corrected transposition from the stance of the conduction tissue is that the ventricular conduction tissue, here carried on the crest of the septum, passes anterocephalad relative to this ventricular septal defect and takes its origin from an anomalous anterosuperior node here formed at the superior end of the area of mitral to pulmonary fibrous continuity. So in fact, the atrioventricular node in congenitally corrected transposition with usual atrial arrangement is found here just beneath the mouth of the right atrial appendage. The bundle penetrates through the superior part of aortic to mitral continuity, and then it passes anterocephalad to this perimembranous ventricular septal defect and descends cephalad relative to the ventricular septal defect. That is totally different from the situation with perimembranous defects in the setting of concordant atrioventricular connection, where the conduction tissue is positioned postero-inferiorly. So the essence of the conduction tissue in congenitally corrected transposition is that the atrioventricular bundle runs anterocephalad relative to the ventricular septal defect, running over and above the subpulmonary outflow tract.